Good afternoon, everyone. My name is Nicole Fernandez. I am the Maternal Infant Health Series Project Manager at Wayside Recovery Center. We welcome you today to hear our topic on making postpartum personal with Dr. Jess today. I will share a little bit about Jess's bio, but I want to share a little bit with you about Wayside Recovery Center. Wayside Recovery Center's mission is to improve the quality of women's lives. Since then, Wayside has worked very hard to become an expert in delivering gender-specific and trauma-informed substance use disorder treatment and mental health services for women and their families. Wayside Recovery Center provides a holistic array of care, including outpatient and residential substance use disorder treatment, recovery, supportive services, supportive housing, adult and children mental health therapy. Additionally, we also provide long-term supportive housing as well as family supportive services. We hope that if you are not familiar with Wayside Recovery Center, that you will also go to our website and look at our maternal infant health landing page. It does house all of the education series there via YouTube, so that if you have missed a session or you want to review a session, they are there for educational purposes. Also, we'd like to give credit to the Minnesota Department of Human Services and SAMHSA, who funds this session, the Maternal Infant Health Series. We are in year 2 of our renewal of this grant, and we are greatly appreciative of our funders. And now I'd like to introduce you to Dr. Jess Daigle. She is a board-certified pediatrician, a NICU pediatric hospitalist. She is also the CEO and founder of Mom and Me MD, a concierge newborn and postpartum care practice that provides in-home care and virtual support to new moms and NICU moms in the 4th trimester, with poor outcomes for mothers and noted mostly in the prenatal and postpartum period. She wanted to build a practice where moms received the personalized care that they needed to help them thrive with their new babies. She works closely with families to help make their postpartum journey be as successful as it can be. Without further ado, I'd like to welcome Dr. Jess.
Hello. Thank you all so much for coming. When I met Nicole to talk about this topic, you're always like, what can I speak about? I do so many roles, but given the attention as of late, especially on maternal health and 4th trimester, I thought it would be judicious to talk about this and also just share my personal experience and how I see it making an impact in the lives of families I work with and in the community of other physicians who also do the same work. Let's see. I don't know why it's not advancing. Do I have to go from here? There we go. Maybe from there. All right. So I love this quote by Dr. Frances Peabody. I think it symbolizes what was my draw to medicine, and I actually used it in my personal statement for medical school. So time, sympathy, and understanding must be lavishly dispensed, but the reward is to be found in that personal bond which forms the greatest satisfaction of the practice of medicine. One of the essential qualities of the clinician is interest in humanity, for the secret of the care of the patient is in caring for the patient. And just a little bit of background about me, just to how I even got to this point, because it is significant in the work that I do today. That's me looking all sprightly. I think I look the same. So my childhood dream from the age of 10 was to become a baby doctor, particularly taking care of sick infants. And that young, obviously you're only thinking about one aspect of something, like, okay, I'll be a pediatrician, I'm going to take care of kids. And that families obviously are a huge part of that, but I didn't really think of it in the way that I do now. So then fast forward to my pediatric residency, I get pregnant. And in my intern year, towards the end of my intern year, I end up having a miscarriage. And for those in the audience who either have personally dealt with that and or work with people who deal with that, October is Pregnancy and Infant Loss Awareness Month. So thinking of you and those families affected. But it was the first experience that created awareness for me of what it really means to be postpartum and what are some typical events and things that can happen to you in a postpartum period. Also, in that I ended up getting pregnant again in my end of my second year, going into my senior year. And because I was considered high risk at that point, I was seen by MFM and I was placed on bed rest at 22 weeks. And I ended up going into the hospital at 22 weeks, and I was in the hospital for 9 weeks, and I had my son at 31 weeks. And so he ended up going to the NICU for about 5 weeks and came home. And again, that added another layer to understanding, one, being postpartum and trying to heal, and also taking care of a post-NICU baby, which he had to go back on a feeding tube. So there were those kinds of challenges. And then later I had another preterm infant at 36 weeks. So this enhanced my patient experiences, because when I started to round in the hospital, working as a hospitalist, one, I worked as a hospitalist because traditional clinic to me didn't afford enough time to really work with families, especially with regard to education, because it's like the meal. You got to keep people going, got to keep people, shuffle people in and out, shuffle people in and out. And so I love the hospital for that reason, because if I wanted to sit down at the bedside and talk with the family for 15, 20 minutes if I need to, I could do that. And so I started to make education of moms, especially new moms and NICU moms, be a premier part of my practice. Because even me as a physician, when I had my babies, I realized there was gaps in even information that was presented to me, as I felt like I was treated like a doctor instead of a patient. And so I wanted to be a part of that change of educating patients and really preparing them for having a baby and what that meant when you come home. And so I did that for about 6 years. And then I wanted to have more impact though. So I started to try to explore, how can I have impact outpatient without sacrificing the connections that I made with families at the bedside in the hospital, which was part of the whole being able to provide the time that was necessary. So I started to do some research, good old Google. And I started to think about, well, how could you go back to old school medicine? Because actually my personal statement, I talked about how managed care was taking over and how one of the draws for me was the old school medicine of the doctor coming to your house. And, you would see things like that on TV growing up. And that was one of the appeals for me, like that you're seeing people at their most vulnerable. And I thought that was so special to be able to help someone in their most vulnerable time period. And so then I ran across Dr. Sanal Patel's practice, and she's in Colorado, and she was a neonatologist doing home visits. And I was like, this is novel. Like, this is somebody bringing it back. I didn't even know that that was possible. So I reached out to her and learned more and became a part of a community of physicians on Facebook called Fourth Trimester Care Docs. And that was where my awareness of the fourth trimester became more apparent as an actual term. So I had been contributing to education about that area, just not knowing that it was categorized as such. And then over the last 2 years, my awareness of maternal morbidity and mortality has increased, again, with a lot of attention being in the news. And so then I thought, this must be a way to bridge the gap in care from antepartum to postpartum. And so thus became my interest. So today we're going to talk about the concept of the fourth trimester and its significance in the postpartum period, the unique needs and challenges faced by the postpartum mom and family in the fourth trimester, and show some data that supports how it's economically important providing this type of care, and also how it is vital and possible, right? So sometimes you're wondering, is this possible? And I know it is. And identify strategies, resources, and support systems that can help provide effective home-based newborn and postpartum care. So how can policymakers and stakeholders and community organizations work together? So what is the fourth trimester? Most of you here probably have heard it at some point, again, with a lot of media attention, but for any layperson who may come across this later on and wonder, so we'll go ahead and define it here. So it's considered a transitional period between birth and 12 weeks postpartum. And interestingly, I always think as a NICU mom, I felt like my fourth trimester was extended because I feel like it began after my baby came home. But essentially, the baby is adjusting to the world and the mom is adjusting to her baby, but also she's adjusting to her own recovery, right? So, physically, mentally, emotionally, she's undergoing a lot of transition. And a lot of that is chemical, which we'll kind of talk a little bit about. But it's also like the psychosocial, right? The idea of you're now responsible for a whole human being. I know me personally, it's not something that I had ever thought about until I was like forced to when I had a child. And then how this transition affects the family dynamic. So I've done postpartum planning workshops and I talk about how the fourth trimester affects 5 areas. So the mom, the baby, the home, relationships, and then like career slash if you decide to be a stay-at-home mom, but your workforce and that kind of thing. And you know, when we think of someone being pregnant, I personally hadn't thought about how your whole life really changes, but it's so important to outline it because we tend to lump things together, and because of that we do families a disservice by not helping them to understand what are some strategies and some ways that they could early on start to plan for their postpartum, and also um, look for ways to be supported to optimize their postpartum experience. So I love a little history because you always wonder like where does all these things come from. So this is kind of the evolution of the term fourth trimester. And actually putting this talk together, I learned about Dr. Kissinger. Thank you, Dr. Patel. Not Dr. Kissinger, sorry. It's Sheila Kissinger, which was a childbirth educator in 1975, who said that there is a fourth trimester and we neglected at our peril. And she was talking about in this paper that she wrote how all of these psychosocial and mental health changes and hormonal changes for the mom affected their experience. And even we know of other papers that show that maternal health and well-being has long-term impact on infant well-being as well. And then in 2002, Dr. Karp, who's a pediatrician, go Peds, he said newborns require months of intense womb-like nurturing for optimal growth and development. But he mostly was coming from a place about newborn sleep. But he was really saying that the baby essentially was still growing. So while we're basically just seeing that last phase of a baby transitioning and changing, which is why their needs are still so much around feeding and sleeping and bonding. And then there started to be more attention towards the fourth trimester with different publications by Harvard Health, Healthline, and Very Well. And then ACOG got on board and put out a opinion about optimizing postpartum care, recognizing that there was a need for comprehensive care, that the 6-week visit out is most likely, and we know for those of us who work with families, is often too far out, that there really needs to be more targeted attention early on, and about the education and oversight that is being provided for moms in the postpartum period. So the fourth trimester is the foundation of postpartum care. So I remember when I was learning this too, is really understanding that first 12 weeks postpartum is a period. And we know a lot of lay people, when they use the term postpartum, they actually use it to describe like being in postpartum depression, but it really is the period of time after delivery. And so the Journal of Prenatal Medicine, and if you have been following this series, you know, Dr. Anastasia Williams talked about this in her, a couple of her talks. And postpartum has these 3 phases. So you have the initial acute period, the first 6 to 12 hours after birth, where you're looking for hemorrhage, things like eclampsia. And then you go into the subacute postpartum period, which is 2 to 6 weeks. And so this is more of the hemodynamical changes, the genital urinary changes, all the hormonal changes as well that are the mom is experiencing as the body is trying to move back towards that pre-pregnancy state. And then there's delayed postpartum period, which lasts up to 6 months. So this is where we're still monitoring for more of like mental health type of changes as well. And so postpartum care is really all of these things that I have listed. So it's maternal health and well-being. So the conditions that the mom may have, pre-existing conditions like diabetes or hypertension, or even some that may have developed in pregnancy. The infant's health. So how is the newborn doing with regard to feeding and sleeping? If their baby has had any type of congenital anomalies, any NICU stay, all of these things get wrapped up into postpartum care. Breastfeeding support and feeding support, because I am pro for breastfeeding, but not at the exclusion of using formula. And I make that very clear to families because there are some instances where formula is recommended and needed. And so even you can see feeding issues just even with formula, with families trying to learn how to feed their baby in both instances, things like spitting up and reflux and different things that require education and support. Emotional support. So again, we talked about those changes that the mom is going through, this realization that life is going to be different from now on. I always tell my families, like, you will never not have to think of your child anymore. And that's like a reality. And so I really try to say, like, this is just an is thing, nothing to be judgmental about, just kind of understanding that this is part of the transition, is natural, normal. And so then how do we support you while you're undergoing these changes, and this transition is key. And then education and counseling. So education about what to expect, what is not wrong. Really big on education. A lot of times it's easy to just tell a patient not to worry about something, but we need to do better at saying, when should they worry? What should they be looking for? Because that is also just as important as saying, oh, that's okay. Well, then when is it not okay? And then counseling. So I really believe that just starting in pregnancy, and I'll talk about this a little bit towards the end, we really need comprehensive care to start in pregnancy and extend it to postpartum. It shouldn't be disjointed. So I love this figure because I love showing how interconnected all of these things are in pregnancy, postpartum, and the fourth trimester. So as you see here, all of these are key things that become important areas to address when you're dealing with the family that's in the fourth trimester as part of their postpartum. So mood and emotional well-being is key. So definitely making sure a family is being screened and connected to therapist, counselor, understanding if there are pre-existing mood disorders is key. And infant care and feeding. So for some families, their first time, their baby is the first baby they may have ever experienced. And I think sometimes we don't do enough to understand what perspective and worldview families are coming from, what is their true background, right? Like the stories matter. And sexuality, contraception, and birth spacing. So what are their plans around contraception? How do they like to identify themselves? What is their family dynamic? What is their view on having kids? They may not have thought about it before, but now at this current kid, they may be thinking about their whole situation a little bit differently. So identifying these measures. Sleep and fatigue. Working with a family now, and I was checking her and she was like, I'm just tired. And I was like, that is definitely to be expected, but we don't just stop there. We explore what are ways to get rest, and then identifying if this sleep and fatigue is part of the natural transition, or is it part of a bigger thing like depression, anxiety, and things like that. And also, just, is her health optimized? Is she really anemic? Things like that. Physical recovery from childbirth. So in order to remember this, I have to do like quick little things like when I took my board. So like PE, so the progesterone and estrogen are now like starting to decrease for the PO, for the prolactin and oxytocin, which help with breastfeeding and, like, helping that uterus to go back down. So all of these hormonal changes are actually impacting the mood. And so that's why this nice little circle here shows that all of this is interconnected. and then medication, substance, and exposure. So I'm part of a group that's breastfeeding doctors doing breastfeeding medicine. And I've loved being a part of that group because it's helped me to understand more from a physician standpoint what medications and things can impact breastfeeding in moms, and what medical conditions can impact them. And so all of this helps us to optimize this fourth trimester, because it is considered that first couple of months. So there's much information as we have about the families going into and then at the start of their journey helps us to optimize their care. So what are some challenges in current postpartum care? Well, we know this lack of adequate care and support, which is kind of part of why this model of doing fourth trimester care in the home is good, because we know in certain areas, we are all no stranger to the fact that certain areas have lack of support. If you've been watching the news, you see that Alabama is closing 3 of their hospitals that do deliveries, and so where those families will go. And so all of this ends up impacting postpartum experiences too, if families have to travel further to go get to different places, and even just healthcare provider shortages. So midwives, OBs, nurses, especially after pandemic, where a lot of people just kind of were burned out. This has also put a strain on access to pregnancy and postpartum care. So in line with that is connected to disparities. So we also see, which this is interesting to me, when I was young and wanted to be a doctor, you're like, I want to help people. And these are not things that you're aware of. You just think, I just go to school, I learn, I get out there and work and help people. But then you start to learn about the politics in medicine and in health, and how so much of policy and stakeholders and all of these things become so important in advocacy and just even real access. Like I travel, I work as a locum. So just going from different states, I see how one hospital may be able to quickly execute this, or this test can be done in-house, or this one has to be sent out, and just things like that. If that's already happening at the hospital level, where you expect to have more access, right? More things at your disposal, you have disparities even at that level. So how much more when you're outpatient and you're having families that are having to travel already from different areas to just get the type of pregnancy and delivery care that they desire, and then they're having to go back out to these like silos where they may not have access to the follow-up that they need. And then the other thing is mental health and postpartum depression. So one, that's also an access thing. So access to therapists ahead of time, the stigma around mental health, which, I think we are doing a better job of putting it out there and encouraging people that mental health is health, but still in certain communities, it's still a challenge, and recognizing that there is no judgment on you. But then we have systems in place, like I know at the hospital, if there's issues, then we have to call in social work, which sometimes ends up resulting in child protective services. And sometimes that can go the wrong way. And so just families not wanting to seek help because they're worried about their kids being taken away. And so they suffer in silence. And then the impact on maternal and infant health. So just all of these things kind of lead into that, because all of these things impact the weeks after, regarding their health and follow-up. If there are medical conditions and that need to be addressed, parents may brush it off. One, because some people have to go back to work, which I thought this is ludicrous, but it's true for a lot of families. And infant health things like, neonatal mortality, morbidity, to do with things like feeding and or SIDS and things of that nature. So this, if you have an opportunity, look up this Listening to Mothers 3, this survey. It's a paper, but it's like a survey. It's the third one. It's really, really neat, done by the Childbirth Connection. And it really looks at asking moms about their experience after having a baby and looking at all of these different measures. And you see that, feelings of depression, breastfeeding problems, like some of the things we talked about, on the previous slide with the connected circles there, feeling stress, heavy bleeding, backache, weight control. So what was interesting to me though was like the major and the minor. So these were things they consider major and like minor. So the minor had more of the of the higher percentages, which I would have thought some of that stuff would have been major. So I kind of wondered if it had to do with like their perspective about it. And sometimes that's one of the things too, right? Like in our communities, we kind of laud certain things as, oh, that's just to be expected. And so sometimes people don't reach out because they just think, oh, since it's normal, it means I have to struggle, because we talk about the struggle of postpartum and fourth trimester. But I've been on a mission to say what is typical does not mean you have to struggle. So it's typical to have some bleeding after you have a baby, but you still need to know how to quantify that and know when you're moving into a dangerous zone. So now we get to the meat of it, the power of fourth trimester care in the home. So doing this allows us to address specific aspects of postpartum health in a personalized and convenient manner. And I remember when I was even just starting, and trying to explain why I think this is important, again, that's one of those things where families are just used to, oh, okay, I'm just going to pack up and, I just had a C-section and like 2 days later, because I know. And before I had kids, I was part of I wouldn't say the problem, but that idea of this is just what we expect. So, I work in the hospital, you have a new baby. Okay, it's a 36-weeker that might be going home in 2 days. One of the things you're worried about is jaundice, right? So I tell the family, hey, we want you to see the pediatrician and within 2 days, depending on what the Billy tool, which is a tool we use to kind of categorize jaundice in newborns. And so this mom may just have been basically cut open to deliver this baby. And now she's got to try to get up out of her bed, pack up a baby, pack up things, get to an office, sit in a waiting room. This is the reality of what we're subjecting this family to, which if we go to her, then she can be resting in her home. I can come there. I can check on the baby. I can look and see how she's healing. Is her blood pressure fine? Screen her for issues that are concerning, educate her family. And this is what that personalized and convenient care means. So like with the family I'm working with now, I was able to, even before she had the baby, learn a lot about her family dynamic and things that would be important, what she was already concerned about, postpartum depression, postpartum anxiety, will she be able to take care of her baby? These are things that if she just was coming into the office at the second day, we don't have time to do that. I know that's why I didn't want to do traditional clinic, because you don't have time to do that. And even now when I work in one of the clinics that I help out with, I get fussed at for being in there long, especially if it's a new mom. I'm like, they need at least a good 25, 30 minutes, but that is not how traditional clinic is set up. Because it's like the number of people you see affects the cost of the practice and, the business of medicine, all that, right? So having the care in the home allows you to witness some early detection of complications as well. So and I'll talk about her story later, but just in a few days, if you're having some blood pressure issues, your pain is in control, your wound is not healing, if someone is seeing you versus that first week out, like traditionally the OB will see them at like now traditionally the 6 weeks, but there's been some push for now, okay, maybe 3 weeks. And I'm seeing more practices doing that, but that's still a little bit later versus if someone is laying eyes on this mom within the first 24 to 48 hours, then we can begin the education of reinforcing, right? Because a lot of stuff is told to a family when they leave the hospital, but it's so much going through their mind. They're so worried about their baby and not even themselves, to be honest. And again, that thought of, okay, well, I think this is just normal. So the reinforcing of the education is key, and being able to go to the home allows that healing recovery, but also the early detection. And then management of chronic conditions. So like the blood pressure and things like diabetes, making sure that those things are followed up. Mental health screening. So identifying early if there's if they're in postpartum blues, or are they moving into postpartum depression? Is there anxiety? Is the anxiety in line with, okay, I'm just kind of trying to learn how to do the right thing, or is it taking over my ability to care for myself and my baby? And then enhanced breastfeeding support. This is really key. This is one of the biggest things I have seen a benefit in. I just checked like about a couple of weeks ago with to a couple of families that I helped, and they were still on target with breastfeeding, which was so huge. And this is families I saw like back in December, and I was like celebrating because they had wanted to give up, but they reached out for help in the home. So it was so beautiful. And again, for me, it's more about them being empowered and educated to know that with the right help and oversight is possible versus, okay, if they just go into the office, if that pediatric office does not have lactation support or things like that, they may just be quick to push formula just because the thing is they want the baby fed, but we know how that can impact the mom mentally as well. And then again, patient education and family planning and access and convenience. So these are just a couple of studies here that you can go back and read, but fourth trimester care in the home has demonstrated benefits with improved maternal satisfaction, things with healing, improved emotional and mental health support. So again, that early screening and them feeling like someone is in it with them, that they're just not, okay, you've had the baby and now, we're only concerned about the newborn and not how you are coping with this transition. Then it allows the family to build a supportive environment. I know this is one of the things I stress when a family comes to work with me is I look at what is their support system and if that is available, and encouraging families to optimize their supportive environment. And you also can integrate cultural sensitivity. And I'll kind of can speak a little bit more about this later too, but I've just come to learn, and this is just being in a hospital as well, that different cultures view postpartum and fourth trimester care in a different way as well. And then you are allowed to be able to provide the care that the family considers personal to them, an important part of their healing and recovery, which is so important because we tend to cookie cutter everything, and that's not a way to go. There are definitely some basics in terms of paying attention, being curious, being educating them, but we need to consider each family dynamic in the experience. So here's a case study. A 36-year-old Black female, G1P2, gives birth to twins via primary C-section at 34 weeks gestation due to PPROM. She has a history of uterine surgery for fibroids and some twin-to-twin transfusion syndrome that she had to have laser surgery for. So she was on bed rest. So she signed up for care with me because she wanted extra support, especially knowing that the babies would be in the NICU. So one of the things I loved was that I was actually able to go visit her in the hospital before she had her babies. And we were able to talk to things like what she needs to ask the NICU for consult, I was even able to learn about her pregnancy experience so far. Like, how was her encounters with her OB? What was that like? What has her education been so far? And I was able to offer emotional support during the whole time that they were in the NICU, which meant so much to her. She's already expressed that, and we're still continuing to work together. So how will this benefit her? She's already feeling supported without the pressure of time constraints from traditional office. So being able to go to the home and see her with her new NICU babies without her having to stress about, oh, I gotta shuffle them over here, over there, because again, she's healing from C-section. She ended up having to go back to the hospital for symptoms associated with preeclampsia. So that again was like a less of a stressor, like, oh, okay, now I was supposed to be trying to get the babies to the doctor and things like that. And I was able to support her husband. So sometimes we put the focus on the mom, but the non-birthing partner is just as important and a vital part of the dynamic. And so considering that whole family is key. So y'all are like, this sounds good, Dr. Jess. It's all fluffy and feels good. But what about the cost? So the cost has been mothers' lives. Okay. And we see here, I remember when I saw this come out, I was like, what? Like, we in the US tend to think we're just always on top of everything. We're the best of everything. And I remember thinking, wow, like we are the worst when it comes to maternal mortality. Like we have the highest. I just could not believe it, but the data is the data. So how is maternal mortality rate calculated? Is recorded or estimated maternal deaths over live births times 100,000. And so this is like the death from pregnancy, irrespective of duration or site, any cause related to or aggravated pregnancy, but not accidental, incidental. So something like homicide. So live birth is if there's signs of life, deliver a complete expulsion of human conception, resulting in baby that has a heart rate, not transient cardiac contractions, breath, not gasps, pulsation of umbilical cord, definite voluntary movement of muscle, irrespective of attachment to umbilical cord or placenta, and this includes a period of time. So lots of definitions here: pregnancy-related death, pregnancy-related mortality ratio, maternal death, and maternal mortality rate. So all of these things are factored into, and some of these kind of have some overlap. So pregnancy-related extends up to within the year, while maternal death is within that 42 days of the end of pregnancy. And this graph kind of shows the distribution of these deaths from non-Hispanic Black to white to Hispanic. And you see that non-Hispanic Blacks have the highest deaths per live births. And we also see that the older you are, as well, those numbers also increase. And we see the other key thing is that these numbers are increasing as the years go on, which is not what we want. So with that, the total fertility rate, though, is expected to kind of be a little bit steady here. So from, in 2023, for the next 30 years is where we expect to go, with women having kids a little bit later. And we know things like career, and fertility issues and things like that kind of lend to the the increase in age. And I was able to learn about this from Dr. Patel. She's famous in this talk. But she talked about the economics of the fourth trimester in a TEDx talk, and she's found this neat little graphic that shows, like, if women's participation in the United States is fully equal to men's, then that's like an overall gain of 4.3 trillion, right? So $13,392 per person increase. So if just saving a life wasn't enough, which you would hope that would be the key driving factor, here is the actual financial proof that it matters. We staying around actually adds to the economy. And I remember when I saw this come out, about like that these deaths in this early postpartum period are preventable. I remember thinking, wow, that is a whopping number. Like 84.2% of the deaths are preventable. And so this is a distribution of pregnancy-related deaths. So most of it is cardiovascular conditions, and then you break it down here to non-cardiovascular, infection, bleeding, amniotic embolism, and then on around to hypertensive disorders. And some of the other data that's come out is that Black women are 3 times at risk for maternal mortality compared to white women and even Hispanic mothers. And so just another way to put it, Black mothers, more cardiovascular conditions, white mothers, more mental health related deaths. And I really like this slide because going back to that 4 out of 5 preventable, this is the time period here. And what is this? This is like the early 4th trimester. So 1 to 6 days postpartum, 7 to 42 days postpartum, and then for like that last part of the year, but most of it in those first 7 to 42 days. So having someone look at you within the first 2 to 30 days is key in catching some of these preventable causes, right? So I know of a case that Dr. Patel shared with me where she had a Caucasian female that had been having some neck pain, and she was going to the home to see her. And because she was able to check her blood pressure, she was able to get her in to be seen. And she ended up having a vertebral artery the section. And so before that, though, she had been calling to say, like, oh, it's just neck pain. And everybody was just prescribing her pain medicine, thinking, oh, you're just in pain. And so someone being there real time at the house, assessing the whole scenario, was key in saving that mom's life. And so this is how our current healthcare system is set up with regard to pregnancy visits. So, every 4 weeks, then every 2 weeks, then weekly, and then, in the hospital and our birthing center. And then depending, again, that 6-week visit, which we know that there's some new guidelines out with ACOG recommending to come in as 3 weeks. But again, that still leaves 21 days where a mother may be left to her own devices and relying on her own education, which may or may not have been done or retained. And then, she's worried about her baby and not so much herself. And so we're there to worry about her and the family dynamic. So we really need a paradigm shift in medicine, dyad care. And when I work in the hospital, I used to always have to fight with my OB colleagues and be like, the mom and the baby matter at the same time. So, and I know this is true because when I'm going to take care of a baby, I have to look at the maternal history. I have to look at labs. I have to look at medical conditions and think, how can this be impacted the baby? And so they are, even though the umbilical cord is being cut, that connection is still there and is vital. Postpartum health is not new. So that's one of the things that was neat for me to learn, is how other cultures are out here doing it and across seas. And so I thought it was interesting that we spend a lot of money on healthcare per person, but we rank last when it comes to maternal outcomes, going back to that slide earlier. So some of the key areas is in readiness. So in some other places like Netherlands and Belgium, I'm looking at my little notes here, postpartum planning begins at 34 weeks. So it's actually part of their routine process to begin postpartum planning and education. And so we may see instances in the US where some of these things are done, like childbirth education, breastfeeding education, but it's not standardized and it's not, again, it's one of those things that depends on where you are and depends on if the mom is aware that they need this, is every OB office, instituting some type of postpartum education. And I know when I have my kids, I love my OB and she's a great doctor, but we didn't talk about the 4th trimester or postpartum. It was more like, quick little symptoms of, I don't know, I was in trouble, which I knew as a physician. And then I was kind of left to my own devices. Now, I didn't think she did not care about me, but if I'm being honest, it wasn't a discussion. So rest and rituals. So in a lot of other cultures, the postpartum period is protected. Like it's like the goal for the mom to do nothing. Like the village is taking care of her, and her only focus is to like heal and like feed her baby and bond and recovery and routine visits. So we'll see on the next slide, like it's regular in a lot of places for them to have some home health. It's part of the normal care is what I'm trying to get at. And also rights has to do with regulation and policy in supporting paid leave, medical leave, how long you can be off. I've heard of some families, like when I would have moms and the babies be in the NICU, they'd be coming back and they're already going back to work. And I'm like, still like 6 months yet. And this was a reality for a lot of our families. So we really need to make 4th trimester home health a normal practice. And this is the other thing too, is like, part of that cost is like, we know that healthcare costs and money needs to be made for providers and folks that are providing this care. But you see here in other countries, is covered by national insurance, whereas in the US, we have some Medicaid programs that may do it. There may be some insurances that do it. Again, it's not consistent and it's not normal, which creates barriers for families. Now, one of the things I do love is here, you see nurse physicians and community doulas. You see a group of folks that are interested in providing this care, which later I'll talk about the collaboration of that, whereas in other places it's more of a midwife or a nurse only. So I love seeing that here, at least we have more physicians that are interested in being a part of, if not leading this movement of 4th trimester care in the home. And so the US has some history with regard to early home visitation, and there are programs. So I'm still learning so much just over the last 2 years since I've been work in this area. And there's a lot of funding, but it's not really towards like just even for-profit places. It's all nonprofit, and it's all kind of spread out without there being like a cohesive flow to the type of care that's being provided to families. And this is a good map of National Home Visiting Resource Center. Shows that there are home visiting programs, but a lot of it is not medical per se, and again lack the consistency. So what we would like to see is like this whole United States like dark blue, right? And it be in the medical sense as well, making sure that we're really paying attention to those key areas that are least causing maternal mortality in our families. So here are some positive things that have been seen for as regard to savings and improvement in home care. So breastfeeding rates are improved. And so we know that how breastfeeding has positive experiences in general. Like the more you do it, has health benefits for mom and baby. Decreased postpartum depression from being in home care. A lot of that has to do with screening, because again, we talked about how that stigma. And then if you're just thinking, oh, I'm just supposed to kind of feel like this, and you're not being screened for it, then that's later and later delay in counseling and therapy and medication that you may need to improve your postpartum experience. And I've personally talked to a lot of moms who felt like that first year cloud of overwhelm and struggle, and they like with their second child, they're looking back like, man, I wish I'd known this and that. So home health can help towards really targeted care for these families. And 50% less emergency medical care. So again, catching like that case I shared with you about that section, the neck pain, that she could have like dissected and been bleeding out and things like that, and had a stroke and things like that, versus, okay, now we can control almost like a preventative measure. And really, I think fourth trimester care in the home is actually preventative care. So as you know, with everything else, we got to get policy holders and makers and stakeholders into the conversation. So how can policymakers and stakeholders improve postpartum care? One, by improving the policies, right? Like laws and regulations and guidelines that support implementing these types of programs, and supporting physicians and other members of the healthcare team who are key. And these people fall under stakeholders. So healthcare providers, lactation consultants, doulas, counselors, all of these people have a hand in the total well-being and recovery of a mom in the fourth trimester. And collaborative effort is key. So as a physician, I do some breastfeeding and I can do the screening, but if the mom really needs counseling and psychiatry, I can be able to say, hey, this is a person that we can connect you with. And so they can have that follow-up, because a lot of times you might just say, in the office, we would be like, do this quick Edinburgh, and then you'd be like, okay, talk to your OB, but do we make sure that the mom went back and talked to her OB? Do we know what her OB said? Do we know if her OB gave her a referral, or was she left with the task of trying to outsource it herself, figure it out while she's at home, trying to feed her baby, and then she just doesn't worry about it because the baby takes precedence again, and then you see how that cycle can ensue. And just realizing that invest in maternal health, again, going back to how we show the cost of it, is key. So really just showing that it is possible. There are state level programs, physician-led practices that increase the screening of health complications and timely interventions. Sorry, I'm running a little bit over time, but challenges and gaps, there are barriers to implementation, again, dealing with access, awareness. So this talk right here is a big part of it, helping with the barrier, like putting it out there, helping key stakeholders and policymakers to think about this as a strategy for improving maternal mortality, and ways to measure the progress, actually getting out there and talking with the families. I really believe like we learn a lot from our patients and our clients, and that we should not devalue the voices of people that we are currently working with. And so in conclusion, postpartum care is personal and it impacts all of us. Fourth trimester care is vital, and care in the home allows more personalized and timely care. And the evidence is there. You know, you look at papers, you just see the families you're working with. I know the families I've helped. And so we really just need buy-in from policymakers and stakeholders to make this normal practice, and it is possible. So one last nugget, because this is something I really think is key. I really think that comprehensive pregnancy care needs to be started like a team. Like I really think a team needs to start from when a mom first comes to the OB or midwife and finds out she's pregnant. She needs all of these people to be part of her team. Her family support identified, a doula that can either follow her through the pregnancy, social worker. What are some needs in your pregnancy right now that we can predict can impact your fourth trimester and postpartum? Optimizing the nutrition, counseling if they already needed it, and even bringing in, like me, like the pediatrician early. Okay, we think this baby might be born earlier. These are some congenital issues that we could be looking for. And all of this makes it not seem like an abrupt change at the end, and the families are trying to scramble to get all this support when they could have been having people following along the whole timeline. So I had a little video, but you can probably watch it. I don't know if I have time to play it. Nicole, do I have time? Okay. All right. Thank y'all for being patient with me. All right. So if you would like more information, visit c4tc.org, which is the Center for Fourth Trimester Care. Lots of good information about how to get involved. And so I want to thank Dr. Nicole Fernandez with Wayside Recovery Center, Dr. Patel for her talk on the economics of the fourth trimester. Such a good talk. Check it out. The Center for Fourth Trimester Care, and my patients and clients who I've served. They inspire me every day to keep this movement going.
Thank you. Thank you so much, Dr. Jess. Wow, wow, wow is what I have to say. If you can read in the chat, so many people are saying, great presentation. It was amazing. They love the nuggets. And so I know we're at 12:58, but are there any questions? You can please drop them in the chat. It'll probably take me too many minutes to allow you to speak. But please put them in the chat if you have any questions. Lots of thank yous. Okay, well, I'm going to make a couple of comments, Dr. Jess, while we're waiting. I appreciated you not only telling me about the mortality and morbidity rates, but also sharing the age range. I don't know that I really keyed on that the 35-year-old to 40-year-old had a higher rate. I didn't key in on that. And then just how you beautifully not only say what we're hearing in terms of time with physicians, having that cadre of team, but really giving the examples of where the intersectionality and collaboration of care supports preventative care, right? And it also is able to address care needs more quickly. And so I just really appreciate your comprehensive approach. I do think there's one quick question. Oh, I thought I saw something in the Q&A. Let me go back. Okay. maybe not there. Michelle's saying the C4TC also has directory of physicians in there who provide in-home medical care across the country for dyads. And then Kelly says Nurse Family Partnership is a great program that provides registered nurses in the home for pregnancy through 2 years old. It would be great to have a collaboration with physicians like you. This is what maternal health care should be.
I agree. I agree. And Carrie, and I think I have reached out. I might have to do it again. I think I sent some letters out to someone, I think locally here in Georgia, but I would have to check. But I have identified that as a possible partnership as well, thinking like it's again about bringing everybody in because not one person can do everything. So that is so important. So I'll have to just check back into that, but that is something I had considered.
Well, Dr. Jess, I am just so grateful that we connected. And I am so excited to mention to you all that Dr. Jess will be presenting again in November.
Yeah.
And so I hope that you will attend that session or just share and make sure that folks are connecting with us here at Wayside so that they can learn of that session. And again, we'd like to thank our funders, Minnesota Department of Human Services, DHS, and also I believe we didn't share this part, but Dr. Jess did not have any disclosures that she needed to share.
No disclosures. Thank you. I told myself I was going to say that, but
that's quite all right. That's quite all right. So we just appreciate you sharing your brilliance with us, and I look forward to seeing you soon. And thank you, everyone who attended. And we look forward to seeing you at another session.
Thank you all. You guys bless me. Y'all have a great day.
Thank you. Have a great day.